Always?
IC tube insertion.
Always? Or is it mandatory to put IC tube here?
More than 2 centimeters.
And actually, what you do is you observe the child and assess whether he is hemodynamically stable. If the baby is hemodynamically stable, right, and if the pneumothorax is not expanding, you can leave him alone without putting an ICTU, right? But remember, you can't go and have your lunch and not to put ICTU. You have to monitor this child carefully, looking for any hemodynamic instability, any desaturations, and periodically assess the pneumothorax. This is expanding. If it's not expanding, if child is clinically stable, you can leave it, right? But if child is clinically unstable and if pneumothorax is expanding, then you are ready, right? So it's not mandatory to put IC tube here. It will depending on the circumstances. But in this one, it's mandatory to put a IC tube. That's the difference, right? So what you do by putting a tube, a needle there is creating this one into this one, right? So you convert a tension pneumothorax into a pneumothorax without tension. The lung will collapse anyhow, right? Whether it is tension or not, possible because of the negative interpleural pressure. Negative interpleural pressure keeps the lungs expanded. So the moment you lose the negative interpleural pressure, lungs will collapse, right? So for collapse of lung, you don't need to have a tension pneumothorax, right? So by this you can't say tension or not. So the features you use for tension pneumothorax is shifting of the mediastinum and pushing down of the diaphragm. Yeah. Okay. So that's what I mentioned here, right? Right. This is the baby who had vigorous resuscitation because child was not responding. So child had to be intubated and ventilated with even chest compressions. What can anyone say? What is it?
Cardiac tamponadis
Due to
chest compression.
chest compression, cardiac tamponadis cardiac tamponadis due to pericardium. Cardiac tamponadis increase pericardial pressure. It interfering with diastolic filling, right? So hyper due to what?
Due to pericardial effusion.
Is there effusion here?
Rib fracture causing bleeding into the pericardial
This
cavity.
cardiac tamponade due to pneumopericardium, right? Not fluid, air in pericardium. Now, what is this structure here? What is this structure? Can somebody tell? What is this?
Aortic arch.
Sorry?
Aortic arch.
That is thymus, right? This is thymus. Oh, this is thymus. This is thymus, right? Thymus usually sits on the heart. If you take a normal X-ray of a newborn baby, thymus is in contact with the heart. There's no space between heart and the thymus, right? But what has pushed the thymus away is air in the pericardial cavity. You can see if you look carefully, there you can see this round air column, and this side you can see this air column going around the heart like that. Can you observe that? මෙතන මේ margin එක පේනවද? air lung margin එකක් පේනවද ඔයගොල්ලන්ට? Yeah. Can you observe that margin? Right? This is this entire thing. This thing is actually in the pericardial cavity, right? So this child has a pneumothorax as well, and pneumothorax has extended into the pericardium, causing pericardial pneumopericardium as well. So again, the management will depending on whether the child is clinically unstable or not. If child is hemodynamically unstable, you have to drain this If child is clinically stable, you can wait and observe, right? You have to, on one side, a patient like this, I wasted the entire night with a needle and a syringe to see whether we need aspiration, right? So you go through the sternocostal angle, right? Approaching towards the opposite nipple, and all the time you are applying pressure on the piston. And once you enter the pericardial cavity, you will find air coming out from the syringe, right? So you have to carefully drain it, avoiding pricking the heart. If you prick the heart, you can induce ventricular fibrillation, right? So these are pneumopericardium. So the main clue is the thymus being stripped off from the heart, right? Same thing is more clear here, right? The round is more clear here, right? You appreciate that halo around the heart. Heart, right? And the shape of the heart is more globular in shape, right? Globe back again. Okay. So this X-ray was taken from a baby neonate because there was some abnormality in the neonatal examination. During the neonatal examination, there was some abnormality. That's why this X-ray was taken. Can you say what would have been the abnormality on examination?
White mediastinum.
Oh, that is good. I told that's because
Upper
of the
mediastinum white.
sorry. Never.
Upper
Carefully, right?
mediastinal whitening.
Oh no, that is the thymus. If this is in adult, yes, you are worried about mediastinum widening and something like a thymoma or a mediastinal tumor, right? But in newborn babies, this white mediastinum is normal. This is due to thymus, right? Don't worry about that. This is normal for newborn baby, right? You can everything. Just look carefully. Sorry?
So asymmetrical Moro reflex
Yeah, due to what?
due to clavicular fracture.
Yeah. Good. There's a left-sided clavicular fracture. There's a clavicular fracture on left side, right? So what will happen because of that? Patient will not move the left upper limb, right? There will be diminished movements of left upper limb. And if you do the LS Moro's reflex, this side Moro's reflex will not be present. It will occur only on right side. So asymmetrical Moro reflex and lack of movements on left upper limb would be the features. If you miss this, if they come back in about 2 weeks' time, you will find a big lump there. I've seen that as well. Sometimes can be missed in the neonatal examination, and then the callus formation takes place. Start to heal, and then you get a big lump in the over the clavicle, right? So, what is the management here? What do you do? In adult, we'll apply a figure of 8 plaster. Figure of 8 plaster. But in newborn, what do you do? We generally leave it alone. We don't do anything unless there is a significant angulation or displacement, right? Even a certain amount of angulation will be corrected because when the child grows, there's remolding taking place. So clavicle will take the normal shape, right? So in a clavicular fracture, in a newborn baby, most of the time we don't do anything. We leave it alone unless there is significant displacement or angulation, right? What the other cause for asymmetrical Moro's reflex? This is one cause of asymmetrical Moro's reflex. What the other cause?
Brachial plexus injury.
Yeah, Erb's palsy, right? Upper brachial plexopathy. What they call Erb's palsy, C5, C6 injury. They now call it upper brachial plexopathy. Brachial plexopathy, upper brachial, and this is lower brachial flexopathy, right? So this happens commonly with difficult labor, mainly because of shoulder dystocia. A large baby come and get stuck, head comes out, but shoulders won't come out. And when you pull it hard, you get fracture of shoulders, right? Right. So these are the newborn baby who was depressed at birth, had to be ventilated, had to have bag and mask ventilation for resuscitation. And child was having respiratory distress from birth. What is the diagnosis?
Diaphragmatic hernia.
Which side? You have to
Left
mention the
side
side.
congenital diaphragmatic hernia.
Left-sided diaphragmatic hernia. Why you say that? Because there are bowel loops on the left hemithorax and nothing in the abdominal cavity, right? There's no bowel in the abdominal cavity. It's almost white, and all the bowel
Bowel
loops are in
shadows
the
can be
thoracic cavity.
inside.
Yeah. And the heart has been shifted to the right side. In this side, this was not diagnosed antenatally. Can you diagnose antenatally? Can you diagnose this antenatally? Is it possible to make an antenatal diagnosis?
Yes, sir.
Yeah, we can diagnose it antenatally, right? So it's important to diagnose it antenatally. What will you do if you diagnose antenatally? If the diagnosis made antenatal, what you do? What you do? What the best approach? Are you going to deliver the baby in Ragama or Kampa?
Get ready to resuscitate the neonate at birth.
Sorry?
Get ready to resuscitate the neonate at birth.
Yeah, but are you happy to deliver this baby at Ragama or Kampa?
No, sir.
Why?
We had to transfer the baby to places with surgical facilities to
Yeah,
correct
pediatric
the-
surgical facility. Yeah, surgical facility.
Pediatric surgical
Pediatric
unit.
surgery, yeah. So the baby should be delivered at a place where there is pediatric surgical facilities available, because this child needs surgery, right? And best way to transfer a baby is what? In utero transfer inside the mother's womb, right? Because these babies are unstable, sick, and having hemodynamic instability. If you transfer them, they might die on the way, right? So best way is to transfer them in utero to a place where there is pediatric surgical facilities, right? So if you have diagnosed this patient antenatally, what is the different management apart from the place of delivery? What we should not do? What should be avoided?
Bag and mask ventilation.
Yeah, you should avoid bag and mask ventilation, right? Because why?
Will expand the bowel.
Yeah. When you do bag and mask ventilation, part of bowel loops, and bowel loops will get distended and compress the medius channel to the opposite side. The inflation rates are given to the ETT, right? So this is birth. This is try bag and mask ventilation. If that fails to resuscitate, maybe we go for intubation, right? But if you are diagnosed diaphragmatic hernia at birth, you straight away intubate the baby. Don't do bag and mask ventilation. Straight away intubate and give inflation breaths via the ET tube, not through the back and mass ventilation, right? That's the reason why we should have diagnosed it antenatally. In this particular patient was not diagnosed antenatally. I had to resuscitate this baby because we didn't know it is diaphragmatic hernia. So we did back and mass ventilation. That's why the entire thing has been expanded, right? So when child was not improving, I checked when I was consulted, found heart sounds go on the right side. Actually, epics was somewhere there, on right side. So somewhere there, I heard epics on somewhere there. So that's made me to think of a diaphragmatic hernia, right? So what we should do apart from that, apart from intubation, what we should do? Other part of management.
Insertion of an NGT.
Insertion of NG tube.
Yeah, good. Why you should insert NG tube?
To decompress the.
Yeah, good. To decompress the bowel loop so that you get the chance of expanding the lungs, right? And then you should avoid feeding your sort of IV fluids, right? And then you have transfer this patient to a place where there is surgical facilities. So what the precaution to take during transfer? Apart from normal procedure of transferring all the things like transfer forms, blood sample of the mother, consent, surgery. Anything else but transport? How do you position the baby during transport? How do you position the baby during transport?
In prone
Any special
position.
precaution you take during transport? No.
Right position.
Yeah, you keep the patient normal side up. You keep the patient on the side, right? With the normal side facing upwards. So that it will facilitate air entering the normal lung better, right? So slightly angulate the patient so that the normal side will be lying superior than the abnormal side, right? And don't ever feed this baby, they make things worse. Generally, it occurs only on the left side, right? Through the canal of Bogdalov. Bogdalov canal right? It doesn't happen commonly in right side. That's because of liver, right? So rarely I have seen cases on right side, but very rare. Most of the cases we see it on the left side, right? So physical signs would be, what would be physical signs? What would be physical signs in this child?
Tachypnea.
Granting respiratory distress, right? So if you ask for physical signs, don't write all respiratory. Don't write tachypnea, granting, recessions occur, right? That will be only 1 mark, right? So write 3 different things. So okay, tachypnea, granting, and recessions will be there. Okay. Well, what else?
Reduce air entry affected sites.
Yeah, reduce air entry, just expansion on affected side. Good.
Scaphoid abdomen.
Scaphoid abdomen.
Deviated apex and presence of bowel sounds in the.
Yeah, good.
Bowel sounds can be heard in the
Yeah.
chest.
You will hear bowel sounds in the chest wall, and there will be medial channel shift to the opposite side with the apex beat. You can locate the apex beat on the opposite side. If in this case, apex beat, right? That is a diaphragmatic hernia, right? What is this? This again, this child has set about mild respiratory distress. These 2 X-rays are showing same condition. What does that show?
Unilateral diaphragmatic paralysis.
Okay, that's a possibility. That's not a common though. It can happen during delivery, big trauma. Stretching of the brachial plexus can damage the phrenic nerve, right? That can cause unilateral paralysis, resulting in paradoxical movements. Yeah, one diaphragm goes down, another one goes up like that. So movement up and down like that. But commonly for eventration of the diaphragm, right? EVEN, eventation of the diaphragm. You can see here, the upper wall of the diaphragm is there. Here, the upper wall of the diaphragm is there. This is the gastric cavable, right? The dome of the diaphragm is there. This is the dome of the diaphragm. You can see the dome of the diaphragm. But comparing this with the diaphragmatic hernia, here the diaphragm is down here, not there, right? So, in a eventation, the bubble loops are in the thoracic cavity, right? Here the bubble loops are in the thoracic cavity, but they are under the diaphragm, right? Not freely in the thoracic cavity. So, this has a better prognosis than the diaphragmatic hernia, and usually you can do it as an elective procedure, right? So, it's called eventation diaphragm. Sometimes you might have only part of the diaphragm going up like that. Not the entire diaphragm, a small part can go up like that, and it looks like consolidation. You might treat it as a pneumonia, right? So, you carefully look for it. Partial eventation, you don't have to do anything unless patient is symptomatic. Okay. Any questions about that? So, if you see this, you get a pediatric surgeon opinion whether to go in and do surgery or not. This is mainly due to the diaphragm is very thin. The dome of diaphragm is thin. So, due to pressure of the viscera, it gets pushed up like that, right? Eventation. This baby was having IOGR and then had a lot of froth in the mouth. These X-rays were taken, 2 different patients showing same condition. What is the diagnosis? Anybody?
Tracheoesophageal fistulas.
Yeah, esophageal atresia, right? Yeah, like in the bulla, but all you can say definitely is it's a esophageal atresia, right? So what happens is here you can see the NG tube has been inserted. It has not gone down, it has coiled and gone up again. After the make X-ray asymmetrical in that. So you can see this clavicle is like that, this clavicle is like that. That is because the positioning is not good, right? Not in position properly. And so this go down like that and coils and go up again. Here again, it goes down and coils up and go up again, right? So it's coiling of the NG tube is the feature. So commonly found in IUGR babies. And the warning sign is there will be a lot of froth in the mouth. Patient having a lot of froth in the mouth. And you should not feed. Right? You should not feed. You leave a NG tube in the upper pouch and transfer the patient for surgical management. Right? If you feed, there is risk of aspiration. Right? So this is esophageal atresia. You can have a tracheoesophageal fistula as well. That means the upper part of the esophagus is blindly ending. The lower part may be connecting with the respiratory tract or not. Sometimes it can be only esophageal atresia without no fistula, or you can have esophageal atresia with fistula. In this one, what do you think? Is it esophageal atresia plus fistula or not fistula? This X-ray, second X-ray, you can see here the bubbles. You can see the bubbles. This X-ray, second X-ray, is it esophageal atresia with a fistula or without fistula? What do you think?
Fistula.
Good, with fistula. Why you say with fistula?
Because they are
We can see the NG tube, continuation of NG tube.
No. NG tube coil has gone from their coil and gone up. Because
Discontinuation.
there is What is this? Bowel loops. You can see air in the bowel loops. So if esophageal atresia, if the esophageal ending blindly, right, and there's no connection between the lower part of the esophagus with the trachea, then there's no chance of bowel getting air. Right? If the esophagus is just down there and got obstructed in the middle, yeah, right? Because the upper end of the diaphragm, esophagus is not in connection with the lower end of the diaphragm. So the air can't go down. Only way air can go down to the stomach is if there is fistula between the lower end of the esophagus and the tracheobronchial tree. Right? Got it? So it's better to have esophageal atresia with trough rather than without trough, because when you have the tracheobronchial fistula with vistula, the gap between the two ends of the esophageal atresia is less. Right? So the surgery is better. So you can get it corrected within one approach. If the gap is bigger, then you have to go on continuous stretching of the upper pouch to get the two ends approximated, or you might have to put something in between the two ends, right? So if there is a tough, surgery is better. So it's important to know whether the bowel loops are there or not. Okay? Got it? Any questions? Harada? Right. Yeah.
Sir, can you explain it again?
Tough, the tough we mean.
Yes, sir.
Now, right now you will have that. Esophagus, right? So there is right. So there is a gap between the two ends, right? There is esophagus. It's not continuing with the upper and lower pouch. So this part is separated. So the air can't go from esophagus to the stomach. So stomach will not have any air in it. Stomach or the gas, the other small bowel will not have any air in it. Like this. If you have the trachea there, and this part is connected to the trachea, then air will go from here to the stomach and the intestines. So if you have a tough with esophageal atresia, you will have air in the stomach and intestines. If you have tough without esophageal atresia without tough, then there won't be gas. So if there is tough, this esophageal part will be longer, so the gap will be less. Right? So you can just one in a straight procedure, you can suture to two half together and continue to maintain. But if there are these are wide apart, then you have to go for multiple stage surgery to correct this. Right? So surgery is easy if there is a tough as well, than not having a tough. Same now. Okay?
Yes, sir. Thank you, sir.
Right. This is a newborn baby with respiratory distress, tachypnea and grunting. This X-ray is taken at 3 hours of age. Term baby born by elective LSCS. Baby appearance normal, but having tachypnea, grunting, mild mild recessions. X-ray taken at 3 hours of age. What is the diagnosis?
Transient tachypnea of newborn, sir.
Good. Transient tachypnea newborn. Why do you say transient newborn? What is the reason? What is transient tachypnea newborn? What is, first of all, what is it? What happens in it?
So there's a delay in the absorption of the fluids in the lungs.
Yeah.
Right.
So in the newborn baby, the lungs are filled with amniotic fluid, right? So during normal survival, the alveoli get rid of the fluid and get expanded. Right? So in these babies, the alveolar fluid getting absorption is delayed. The alveolar contain air, so they will be having tachypnea and grunting because of the alveolar containing fluid. Right? So it can be mistaken for surfactant deficient lung disease in a preterm baby. But in term baby, it is most likely diagnosis. Right? And again, more common in babies born by elective cesarean sections. Right? And actually, it's a diagnosis of exclusion. Generally, if it is surfactant deficient lung disease, a rule of 4. Right? Rule of 4 can apply whenever. That means the respiratory distress should be, they start before 4 hours, should be there by 4 hours, and last another 4 hours more. Right? So it should be there by before 4 hours, should be still there by 4 hours, and be continuing after 4 hours as well. Whereas transient tachypnea newborn will improve with time, and by 24, definitely it is gone. The distress is gone. Right? Unless there is some other pathology as well. Whereas surfactant deficient lung disease, it will get worsened for about 48 hours and then plateau and then improve. Right? So transient tachypnea newborn will be stable or getting improved with time. But SDLD, you will have a situation where the distress is progressively worsening with time and then plateau and then improve. Right? So there's a difference. So the most important X-ray feature is increased bronchosvascular markings. You can see the bronchosvascular markings are very thick, and this arrow. What is the arrow indicating? Anybody? Can anybody guess? It's සුදු පාට අරගෙන මොකද වෙන්නන්නේ? That is transverse fissure. That is the transverse fissure, right?
Transverse fissures.
Transverse fissure. So why is it opaque like that? Common transverse fissure pain nene?
Fluid accumulation.
Yeah, it make lymphatics got up, there are a lot of lymphatics in it, and because of increased fluid being absorbed to this, the transverse fissure becomes opaque, right? So this prominent transverse fissure, white transverse fissure, is a clue to the diagnosis of transient tachypnea of newborn. Right? I can see this one also has increased, make a fissure pain, but you can see this streaky shadowing, right? Not like in surfactant deficient lung disease, streaky shadowing, not diffuse, mainly around the central part of the chest, right? Streaks, okay? Bronchosvascular markings are very prominent. Okay? Actually, you don't need to do anything. You can give them CPAP or some oxygen via nasal pronouns. That's what you only need. They'll improve spontaneously, right? So it a diagnosis exclusion by excluding other causes of respiratory distress. This is a preterm baby who was apneic at birth, had to be resuscitated, and on day 3, he was very ill and had bile stain vomiting. Again, this trigger. This is a preterm baby born at 29 weeks of gestation. Had to be resuscitated and ventilated. Became very ill on day 3 with abdominal distension and bile stain vomiting. What is the diagnosis?
Necrotizing enterocolitis.
Good, necrotizing enterocolitis. Actually, the history is itself is diagnostic, right? But what are the features in the X-ray that say that? What features in the X-ray? Sorry? X-ray के बना 3 features suggest करा.
Dilated bowel loops can be seen.
Good. Yeah, can you dilate distended bowel loops are there? Other thing is thickened bowel wall, right? The bowel walls are very thick. That's because the bowel walls are edematous. Right? Bowel wall thickness. Here the bowel walls are very thick. Right? That's because edema in the bowel wall. Right? So after a while, if you don't treat it, what will happen? You will get air bubbles appearing inside the bowel walls. Right? My bowel wall like right? What do you call that? What do you call that? This air bubbles appearing in me. Right? Air bubbles appearing inside the bowel wall. Nematosis intestinalis. Right? Call that nematosis intestinalis. The air bubbles appearing in the bowel wall. And then afterwards, you will find a track like this. Air bubbles forming a track like this towards the liver. What is that? Air bubbles in the portal track. Right? Portal, yeah. The portal track digge air bubbles in a line. Right? So the second thing is that. And then what happens? Ultimately, bowel will burst, rupture, and cause free air in the peritoneal cavity. Air gas in the peritoneal cavity. Right? That's the end result. Right? So this is what you see. If you open up this bubble, they are necrose. Right? Dead bowel loops. Right? This commonly happens in the and who are fed early with formula milk, concentrated milk. They still can be a protective effect, right? But if you give concentrated milk, they are more likely to develop this. And if you have put umbilical catheters, then it also risk factor for necrotizing enterocolitis, right? Those are risk factors. So if a child has bile stain vomiters, then this is one of the differential diagnoses you have to think of. A neonate vomiting bile stain vomiters. If you have a child who is on umbilical catheters and child is ill and having bile stain vomiting, you had better remove the umbilical catheters, right? Because umbilical catheters are a risk factor because this commonly starts by interfering with blood supply to the gut, primary problem, right? So during asphyxia, blood pressure drops, right? When blood pressure drops, blood is deviated from the gut to maintain circulation to the vital organs. So, but the bowel gives, and then on top of the bacteria will multiply, right? That's why the birth asphyxia is more likely to cause necrotizing enterocolitis. And when you put umbilical arterial catheters, again, the umbilical artery catheter can obstruct openings of celiac trunk, superior mesenteric artery, inferior mesenteric artery, and interfere with blood supply to the intestines. So that also risk factor for neck, and other risk factors are large PDAs and fluid overload. Those are also known risk factors for developing necrotizing enterocolitis. Right? So the features are distended bowel loops, thickened bowel loops, air in the bowel wall, then air line in the portal tract, and then after perforation, free air in the peritoneal cavity. Right? Any questions you want to ask about that? Clear? Okay. This X-ray was taken because an abnormality was noted during neonatal examination. What was the abnormality noted? Why was this X-ray taken? Can somebody tell? What was the indication to do this X-ray?
Sacral pit එක.
No. මේක මොකද්ද මේ තියෙන එක මේ arrow එකක් තියෙන්නේ මෙතන මේ බෝලයක් තියෙනවා මොකද්ද මේ? That's the clue. But to damage the abnormality in the baby to take this X-ray. අන්ත කරන්නේ උඩි බැලේ අතරනේ. A prawn X-ray. Not a supine X-ray.
The meningomyelin.
Why do you take X-ray for meningomyelin? Now this child had anal atresia, right? Absent anus, right? So what you do is you put the patient on prone position, right? And with buttock somewhat in a higher position. So allow air to travel up the bowel, right? And then you keep a radio opaque particle like the arrow or this like this round substance where the anus should be. Right? And then you take X-ray, lateral beam, horizontal beam laterally, right? And you see the distance between where the anus should have been and the upper end of the air column, right? Then මෙතන upper end of the air column within මෙතන. And the anus එක මෙතන තියෙන්නේ. මේකේ upper end of the air column තියෙන්නේ මෙතන, anus එක මෙතන තියෙන්නේ. මොකද වෙනස? Hello? Oh. හරි ඒක ඩිස්චාර්ජ් කරන්න ඕන. හරි. ස්මෝල් වන්න. one week බලන්න කියන්නේ. හරි. Oh. Right? So this one is high anal atresia. This one is a low anal atresia. Another. So this is the upper end of the lowest most end of the bowel, patent bowel. මෙතනින් එහාට bowel එක නැහැ. So entire maybe rectum and part of the anal canal is missing. Here, the low end of the anal canal is missing. Rectum is there, right? So why do you want to make the difference? Why do you want to differentiate the two conditions?
Management is different.
Yeah,
Surgery.
management different. Good. What is the difference? In this one, only small distance, right? Missing. And you might even do it in a single stage operation, right? Single stage operation can correct the defect. Here, the defect is very long. So you can't correct it by a single operation. You better do it stepwise and multiple surgeries to correct it ultimately, right? So this is the appearance where you don't see the anal opening, right? What you do is you create a, what is this? What have we done here?
Stoma.
Yeah, a colostomy. Yeah, gone for colostomy. In general, we don't keep backside, just once we keep it as open. Create a colostomy to divert the stool from this end. And then with stage procedure, you create the anus. And once the anus has been satisfactorily created, you re-anastomose it to the bowel. Right? So for this, so decide whether to go for a refunctioning colostomy and stage repair or to do a straightforward surgery. You need to know with this high anal or low anal atresia. Right? So you call this a crustable lateral shoot. This is a lateral shoot to keep the patient upside down. This is actually invertegram. Invertegram is that we held the patient upside down for a while and then took the X-ray. But nowadays we don't recommend to keep the baby upside down because there's risk of aspiration. Okay. This is a anal atresia, right? And if you see anal atresia, what we should do? Anybody? If there's anal atresia, anything else you have to do? You have to look for other abnormalities as well, because anal atresia can be associated with rectal abnormalities, right? So there can be other abnormalities in other parts of the body if there's anal atresia, right? So look for those as well. Right. This is the baby who bile stain vomiting after birth. What is the
Duodenal
diagnosis?
Duodenal atresia.
Duodenal atresia, right? Duodenal atresia. What this is what you call what? Appearance?
Double bubbles.
Double
Double bubble
bubble.
appearance. Double bubble appearance, right? So this is the distended stomach. This is distended duodenum, first part of the duodenum. Usually the obstruction is below the opening of bile duct. Opening of the bile duct. So bile duct is opening and so bile will be coming into the lumen, right? So that's why child will have bile stain vomiting. But if it is pylori stenosis, there is an obstruction at the distal end of the stomach, then there's no bile coming in, so there will be no bile in the vomitus. So the one differential factor for pylori stenosis and duodenal atresia. Other differential factor is that pylori stenosis does not occur at birth. It takes about 2 to 3 weeks to develop it, right? Maybe about 2 to 3 months, but at least 4 weeks to develop pylori stenosis. It's not that birth, but duodenal atresia is there at birth, right? So in a persistent vomiting and newborn period, the pylori stenosis will be unlikely. More likely to be a duodenal atresia or distal obstruction, right? It's common in what condition? What baby?
Downs babies.
Trisomy 21.
Downs babies, yeah. They're more like okay, Downs babies, right? So if we have a child with bile stain vomiting, we have to think of 2 conditions. One thing is necrotizing enterocolitis. Other one is distal bowel obstruction, right? That is below the opening of the bile duct, right? Now what is this? This child had bile stain vomiting and not tolerating feeds. What is the diagnosis? Babala දෙන්නෙක් X-ray එකක් තියෙන්නේ. But same condition in both. What is this?
Pylori stenosis. Sir.
No, but may bowel
Volvulus.
Volvulus, sir?
Yeah, good.
Volvulus.
Yeah, it's a malrotation of the gut, right?
Volvulus.
Because but not this can lead to volvulus. Volvulus silent. This is malrotation of the gut, right? So but most obvious thing is bowel loops are confined to 1/2 of the abdominal cavity. Bowel loops, this side is totally empty. Bowel loops are all on this side. Make it something empty. Empty bowel loops are only on this side, right? That is because now the midgut loop, right? Midgut loop generally develops outside the body, and then it turns to the peritoneal cavity in stepwise manner, right? It takes 3 90-degree turns anti-clockwise. So ultimately 207 degrees rotation take place, so that it will be in correct position like this, right? So sometimes this rotation does not take place properly, and then that leads to bowel loops in one side of the abdominal cavity, and that leads to very narrow mesentery. The mesenteric attachment will become so narrow, right? So mesentery can twist around itself. Right? So mesentery is run from right iliac fossa, where ileocecal junction to the attachment to the duodenum. Long mesentery is attached to long distance in the posterior abdominal wall. When there is malrotation, mesentery is attached to a small area. So the bowel loops can twist around it and cause volvulus. Right? This needs urgent surgical correction. You have to anchor this bowel loop to prevent twisting it around itself and causing a volvulus. Right? You know, the clue to the diagnosis is bowel loops confined to one half of the body, one half of the abdomen. And again, this can present as bile stain vomiting because of the obstruction caused by it. Okay. What is this? Again, this child presented with a distension, feet intolerance, and vomiting. What is the diagnosis?
Intestinal obstruction.
Yeah, where?
Small bowel obstruction.
Small. Hello? Right. Okay, sorry. So there is multiple fluid levels, right? Distental bubble, and there is multiple fluid levels, and including hostrations as well. Can you see hostrations? Yeah, hostrations. This for me, harahara in valves lageva. Hostrations are there in the small, large bowel. And there's a lot of bowel loops are involved, more likely to be a distal bowel obstruction, like maybe a bit of a Hirschsprung disease, right? So it's more like a distal obstruction because large bowel also distended, right? If it is small bowel obstruction, large bowel will not be distended. This is the transverse colon, this is descending colon, and the characteristic hostrations, right? So that's there. So most likely a distal obstruction. Okay? Are there? Right. This is, are you tired? Do you want a break? Hello? Do you want to continue or want to break? Innadulame? Hello?
Yes, sir, we are.
You want to continue or want to break? Tired? Too much? Okay. Right. This is the X-ray of a newborn, day 2-old baby who was having cyanosis. What is the diagnosis?
Transposition of great arteries.
Good. Transmogate artery. Why is it transmogate arteries?
There's a string on egg appearance in the heart, sir.
Yeah, the egg lying on its side. Part looks like egg lying on its side, right? Characteristic feature of transposition of great arteries, and what else? Thymus. We saw big thymic shadow in the early X-rays. So thymic shadow is absent, right? Thymic shadow is absent, and the aorta and pulmonary artery now sitting in same alignment, AP diameter. Right? So the pedicle is narrow. Pedicle the pedicle is formed by this part is formed by the aorta and the pulmonary artery. Generally, they sit side by side together. They form a border pedicle. In transposition, they sit on superimposed to each other, and there is absent thymic shadow. So all these things are features to suggest transversion of great arteries. And again, cyanosis in day 1 or day 2 is more likely to be due to transversion of great arteries, right? Can you do it? Can you correct in Sri Lanka? Can you do correction of transversion of great arteries? Yeah, we can do, right? We can do surgeries here. And for this patient to survive, they actually plus or minus VSD, otherwise they can't survive, right? So if you have a transfusion of great arteries with the intact ASD, what do you do? If you have a patient with transfusion of great arteries with the intact ASD, what do you do?
Atrial septostomy.
Yeah, atrial septostomy, right? Otherwise they will die because the blood that will go to lungs come back to the same side, right? Right ventricular blood up or right ventricular main, right? This is again neonate with respiratory distress and cyanosis.
This
What
is
is the
tetralogy of fellow. Tetralogy of
neonate,
fellow.
right? 2-day-old neonate. It's not tetralogy of fellows.
Tetralogy.
It's not tetralogy of fellows. Can anyone else guess? Anybody else? It's similar to tetralogy of fellows, but it's not tetralogy of fellows. Yeah, it's critical pulmonary stenosis, pulmonary atresia, right? Pulmonary atresia, because of
Tetralogy of
pulmonary
fellows.
atresia. Sorry? What is it? Now, in this one, because of pulmonary atresia, right ventricle hypertrophies. Right ventricle hypertrophy, right ventricle forms the diaphragmatic board of the heart. Because the right ventricle hypertrophy, apex shifts upwards. Right? Apex is shifted upwards like that. That's what we call the boot-shaped heart. Right? Boot-shaped heart in fellows, you don't get this at the time of birth, and they won't get cyanosis at birth. Because in fellows babies, the pulmonary stenosis is minimal at birth. Right? The PS is at the level of valve in the fellows babies at birth, and then the infundibular part of the stenosis develops with time. Initially, the PS is due to the valvular stenosis, but significant stenosis takes place at the infundibular level. So the PS will progressively increase with time, and with that, the right ventricular pressure will increase, and then at the latter part of infancy, the right ventricular pressure will exceed the left ventricular pressure, and shunt will be from right to left. Then they develop cyanosis. So cyanosis at early part of infancy is not a feature of fellows tetralogy, right? Because the PS should develop to a certain degree for reversal of the shunt, right? So if you do this style at pulmonary stenosis atresia, so no blood is going from the right ventricle outside, the blood in right ventricle is going to the left ventricle, and from left ventricle went to the aorta, and through the ductus it went to the pulmonary arteries, right? So if the ductus closes, then what happens? No blood goes to the lungs, and pulmonary circulation will be totally cut off, and child will die, right? So that is what we call but circulation. It's a duct dependent circulation, right? ඕක අනිත් පැත්තට එන්නත් පුළුවන් aortic පැත්ත නම් critical aortic stenosis එකකදී interrupted aortic arch එකකදී severe aortic stenosis එකකදී same thing happens other way around, right? No blood goes out from left ventricle, so blood from left ventricle go to the right ventricle, from right ventricle go to the pulmonary artery, from pulmonary artery they go to the aorta by the ductus arteriosus. So ductus maintain the circulation. If ductus close, they will die. So in that situation, you have to keep the duct open by giving prostaglandins, right? That's why you should never give indomethacin or paracetamol if you clinically diagnose a ductus arteriosus without doing echocardiogram, right? Remember that if you detect a PDA, clinical PDA in a newborn baby, don't rush to give NSAIDs to close the ductus before you do echocardiogram, because the ductus may be life-saving. Maybe duct-dependent circulation, and if you close the ductus, patient will die, right? So in those situations, you have to keep the ductus open, not to close it, right? So if you have PDA, always make sure you get a echocardiogram to exclude the duct-dependent circulation. Okay, right. What is this? Again, the child is cyanosis. A cyanotic child.
The coarctation of aorta?
No. What does heart look like? ඉලක්කමක් වගේ පේන්නේ නැද්ද heart එක? heart එක ඉලක්කමක් වගේ පේන්නේ නැද්ද? අට ඉලක්කමක පේන්නේ නැද්ද මේක? Right? Or snowman කෙනෙක් වගේ? That is called figure of 8. Heart, a figure of 8 or snowman appearance. Right? You get it in the entire total anomalous pulmonary venous drainage. Right? Here what happens? The pulmonary venous blood does not go to left atrium. It goes like that and then into the SVC and drain into the right atrium. And to the foramen ovale, it goes to the left atrium. So because of all these vessels are dilated, right? It is too much of blood flow in it. It causes dilatation of this part to get this figure of 8 appearance. This supracardiac shadow is formed by this abnormal blood vessel network. Okay? Another? So this is what we call figure of 8 or snowman heart. It's due to total anomalous pulmonary venous drainage. What do you call this? This is what we call a globular heart. Right? Globular heart, will have a globular heart. You know, this is what a globular heart. Globular heart means heart is like a globe. Bolak. Perfect bolak. Right? Don't call everything a globular heart. Right? This is what we call the globular heart. It's like a globe. Bolak. When you get it, in which condition you get it? You get it when there's biventricular hypertrophy or pericardial effusion. Right? These are the DDs for by a globular heart. Okay. What is this? This is older child with cyanosis.
Tetragophalanx.
This is fellows, right? This is fellows. Typical boot-shaped part. May apex shift a little bit. You can see the apex is shifted up like that, like a boot. A boot 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 yeah. And you can see the lung fields are more white or more black. Lung fields are more black, right? Lung fields are more black. Why is they more black?
Due to the pulmonary stenosis.
Yeah. So reduce blood flow to the lungs, right? Reduce blood flow to the lung because that's pulmonary stenosis. So the lung fields become more blackish, less blood in the lungs. You call that pulmonary oligemia. right? Pulmonary oligemia, right? So in PS, there is pulmonary oligemia when there is left to right shunt, blood forming from VSD or ASD, but going from left side of the heart, right side of the heart, you get more blood going to the lungs, right? Because more blood from left side go to the right side and go to the pulmonary artery, you know? So there's more blood in the lungs. You call that pulmonary what? Pulmonary plethora. Pulmonary plethora, right? So that might actually more wide. Okay. So this is chest X-ray of a infant who developed coughing while feeding.
Milk aspirations. Aspiration.
Right. Leading to what? What has caused?
Aspiration pneumonia due to milk aspiration.
Where is it involved? Which part of the lung is involved?
Apical areas, the right side apical.
Yeah, right apex. So this is actually a collapse. Right? Right upper lobe collapse. Right? So commonly, if you aspirate something on lying down, supine position, is more likely to enter your right upper lobe. If you aspirate something is erect position, you are more likely to end up in the right lower lobe. Right? Because the most dependent part in supine position is right upper lobe. Most dependent part in erect position is right lower lobe. Right? So a child lying down and feeding, if you aspirate, more likely to go into the right upper lobe. This is right upper lobe collapse. Right? And this is what? This is right upper lobe. Again, right upper lobe pneumonia. Right? This is right upper lobe pneumonia. So how to differentiate a pneumonia from a collapse? In a collapse, right? The body will be convex or concave depending on where it is. Right? Right, upper lobe na concave වෙනවා. Lower lobe na concave වෙනවා. Upper lobe na convex වෙනවා. ඇයි මේ? මේ හරිය ලං එක බලද්දි මේ හරිය ලං එක මේ හරිය ලං එක මොකද කියන්න පුළුවන්? Lungs in this part of the field and this part of the field. What's the difference? Lung field here and here. මේ හරිය lung field එකයි මේ හරිය lung field එක මොකද කියන්න පුළුවන්? පාට මොකද්ද? This area is more black compared to this area. Why is that?
Due to expansion of the lung, due to
because the lung has been collapsed. This upper lobe has collapsed, right? So the adjacent area has hyperinflated to take up that space. So what is this line? This line is transverse fissure. This line is a transverse fissure. Usually it's a horizontal line. Right? Why has it gone up like that? Because hyperinflation has gone and compressed the collapsed part. Right? So it becomes very sharp margin, sharp border, right? And convex line. Right? Right? Lower lobe, same thing. So මෙහෙම border එකක තුල එන්නේ. Right? See? So this one, you can see a horizontal line and not a very clear-cut margin like that, right? and the shadow is more homogeneous like the previous one. Making a ground glass in between the and this one is very clear margin, homogeneous shadow, and no air inside it. Right? So those are things make you differentiate a collapse from a consolidation. Right? This is a consolidation. This is a collapse. Clear there? Are you clear about it?
Yes, sir.
Now what is this structure? Yeah,
This is thymic
shadow, right? So this is thymic shadow in children under 5 years. Sometimes you can have shadow like that. Usually thymus sits directly on the heart shadow, but especially if the film is rotated, the thymus can form an additional shadow like that, right? And it looks like a sail or so we call it the sail sign. Right? Sail sign. SAIL. SAIL anyway. Right? So don't mistake this for pneumonia and treat with antibiotics, you will never heal it. Antibiotics, right? So you but on the other hand, don't miss the pneumonia thing, it is a thymic shadow. Okay? So be careful of this one, right? And especially common if there is the rotation of the film, right? What is this one? A child, a 5-year-old child with fever and cough. What the diagnosis?
Middle lobe pneumonia.
Right, middle lobe pneumonia.
Right, middle lobe pneumonia. Good. So the feet border clearly, right? Right heart border pain. Right? So what I remember is lung is a 3-dimensional structure, and you're looking at the 3-dimensional thing in a 2-dimensional plane. Right? So the right middle lobe is only in anterior. It's not there posteriorly, right? So right middle lobe correspond to area just lateral to the right heart border. Right? Not this area right middle lobe. Right? Because horizontal fissure goes the transverse fissure, transverse fissure goes like that, right? Not like that. So like that. So if there is right middle lobe pneumonia, you can't see the right heart border clearly, right? That's the way to diagnose right middle lobe pneumonia. This one.
Right lower lobe pneumonia.
Right lower lobe pneumonia, right? So in right lower lobe pneumonia, what feature is that you can't differentiate consolidation from the diaphragmatic border. Here you can see the diaphragm. Here you can see the diaphragm. The shadow overrides the diaphragm dome. Dome shadow continue. See, you can't see the dome of the diaphragm, right? So here you might be having right middle lobe pneumonia as well, which you can't see, right? So when they have right lower lobe involvement, you might in APV you might not see the right middle lobe as well. In that you might have to take a lateral X-ray to see the right middle lobe, right? But here you can only say there is right lower lobe pneumonia, right? So if you take all three to so what is this then? What is the diagnosis here?
Right side
Child fever and difficulty in breathing.
Pleural effusion.
Pleural effusion.
Pleural effusion. Yeah, right side pleural effusion, right? Here you can see the difference in this one, this one. Now here, the shadow is more diffuse and margin is ill-defined and flat like that, right? Not going up like that. In this one, you can see the margin, clear margin going up like that. I mean, meniscus is formed. This is the fluid, right? This is pleural effusion. What is this? This is a 8-year-old boy with fever. X-ray. A child was ill, and X-ray was taken in the ward. What do you see? What is the diagnosis here? This is again the pleural effusion, right? Pleural effusion taken on supine film. When you take a supine film, the pleural effusion layers the posterior border, posterior surface of the heart, sorry, surface of the lung, pleural cavity. So it will form homogeneous shadow like that. Not the normal meniscus. For you to see the meniscus, you have to take the X-ray in the erect form, erect X-ray, erect chest X-ray. You do it on supine film, that hemithorax will be white. Compare this side and this side. And generally, this is a diagnosed child is dengue fever. They get tight pleural effusions. That's why this hemithorax is looking more whiter than this side. Right? This one, what is this X-ray called?
decubitus position.
Yeah, lateral decubitus view, right? So when you have this child, if you did it like that, this is what you do. So if you take the patient to a side and take a lateral X-ray, right? Then you see it like that. The fluid layer in there, right? Now will accumulate at the lower part of the thoracic cavity like that, right? So this how will appear in the chest X-ray. So if you have a child who is ill, where you can't take the child to the X-ray department to take erect film, and if you suspect a pleural effusion, rather than taking a supine film, better get a lateral decubitus film. Right? Right. So we'll just look at the 3 pneumonias together. So you will not miss again. So this is right upper lobe pneumonia, where it involves upper part of the lung, and you can't see air above this area. This right, this transverse fissure, and anything is opaque, right? Right, mid-lobe area, you can't see the right heart border. Then right low lobe pneumonia, you can't see the diaphragmatic surface. So don't miss it again. You see this, right? These are the characteristic features of lobe pneumonia, right? And this is what? The bronchopneumonia, right? So other one, this is lobe pneumonia, this is bronchopneumonia. What's the difference between lobe pneumonia and bronchopneumonia? Main difference?
Whole lung is affected in the bronchopneumonia.
Okay, in lobe pneumonia?
Lobe of the lung is affected.
Should it be an entire lobe? And we have segments of a lobe?
It can be segment of the lobe as well.
So how to define it?
The infection is localized to a segment or a lobe of the lungs in lobe pneumonia.
Yeah, actually it's a pathological diagnosis, not anatomical diagnosis, right? So lobe pneumonia means the inflammation is confined to anatomical demarcated area of the lung. It does not need to be lobe, it can be segment, right? Or several segments, not the entire lobe. It can be lobe as well, or maybe more than one lobe. But by definition, in lobe pneumonia, the infection is confined to an anatomically demarcated area of the lung. Whereas bronchopneumonia, it is diffuse involvement of the lung, where there is more than several parts of the lung will be involved. It can be involve both lungs as well. Now you can see this one, there is fluffy shadows involving both lung fields, right? Not confluent areas. Now in this one, you can see the confluent areas and more homogeneous areas. Here is not homogeneous. dot like appearance, right? That's what we call bronchopneumonia. General bronchopneumonia occurs at extremes of age. That means the very young children and older people, as well as when the organism is very virulent or the patient is immunocompromised, right? Because the body can't localize the infection to a particular part of the lung. Infection spreads throughout the lung rapidly. So that is what we call the bronchopneumonia, right? So bronchopneumonia usually is more severe than the local pneumonia, and even sequel is more with the bronchopneumonia, right? I think there are about most slides, about half slides are left. I think we'll stop it here because it's too long otherwise. We can't finish everything today. So we'll do it another day, right? Rest of it. There's bones, there are renal, and some of the respiratory cases as well. Right? So important thing is you see X-ray. The problem is you're not seeing patients nowadays. Not going to watch enough. But when you see X-rays, look at them and get your eyes familiar with normal X-rays even. And then you will see abnormalities very easily, right? So make sure you see all the X-rays you can get hold of and see as much as number of X-rays you can, right? So I think we'll stop it here and we'll do it another day. The best step can contact me, the group monitor, contact me for a date for the rest of the X-rays, right? Okay.
Excuse me, sir.
Yeah.
Can you please give us the record as you are doing housemanship? We missed some parts, sir.
Okay, I'll take a recording and problem එක මේ ඉඳලා internet ගොඩක් slow. මේ ගොඩක් ඉදදුර තියෙන it's a big one very big file.
Yes.
So sending it will be a problem. එහෙම නම් pen එකට දාලා දෙන්න ඕන. Right? I'll record it. Okay?
Okay, sir. Thank you, sir.
Okay. We stop
Thank
it
you,
there.
Monica.
Right? So the monitor contact me. So we'll do the rest of it on another day. Right?
Okay, sir. I will, sir.
Okay. you.